Our next speaker is George Thompson. GR is a professor of medicine at the University of California, Davis Medical Center. He has a joint appointment in internal medicine, Division of Infectious Diseases, and the Department of Medical Microbiology and Immunology. And parenthetically, he is the chair of the working group for this meeting.
Thanks so much, Neil, for that introduction, and thanks for the opportunity to speak a little bit about current therapy for coccidioidomycosis. And we'll take a bit of a very short voyage through past and present treatment options. And really the key questions to spend some time with today are the natural history of the disease prior to antifungals. I think that's key to emphasize, and we'll talk through the specifics of why. What are our early treatment options and what are the limitations with those? The duration of therapy for some of these patients is really a challenge. It's very difficult for these patients to stay on medication for long periods of time. And then one of the things we spend a lot of time talking about in the clinic is patients with infection at a so-called sequestered site. That's a site that we cannot get a great amount of drug into, such as the bone and particularly the central nervous system. There's a lot of toxicity with the current agents given the duration of therapy that these patients receive. And then some things that come up very frequently in the clinic with drug-drug interactions, therapeutic drug monitoring, and then resistance. And I think that's really emerged and been recognized as a problem in the field just over the last few years. So you've seen some version of this slide already today. If you take 100 patients, right, 60 of them will probably not have symptoms that come to clinical attention. They may have some symptom, I think, but not those that are ultimately diagnosed with coccidioidomycosis. And so I've circled this with yellow here for those patients that have really a primary pulmonary infection, that is infection just limited to the lung. And then those with complicated infection, that's outlined in orange here as well. So those in the yellow circle, really with primary pulmonary infection, I think that there's been considerable debate about should we treat these patients, yes or no. We know from natural history studies and the pre-antifungal era that the vast majority of these patients will self-resolve their illness. And there's a bit of an Arizona versus California debate even in this. I think the California groups, we tend to treat patients that present with symptoms, and I think Arizona does a lot more counseling to those. I think that the truth is probably somewhere in between of what we should be doing. And then the group that we all do agree to treat are the heavily immunosuppressed patients. Those are patients certainly at risk for bad outcomes. Those with diabetes, particularly uncontrolled diabetes. And then patients that just tolerate any respiratory illness poorly, so cardiovascular disease. And pregnancy, Neil nicely outlined the patients who really struggle with cocci when they acquire it during the second trimester. I tend to not treat everybody that's Filipino African American. I don't take that into that heavy of consideration for treatment. I do take that into consideration for how long to follow those patients for concern of complication. And then the guidelines also talk about treating everybody with exceptionally severe primary disease. And then those with complicated infection, and we'll go through this in a little more detail on the next slide, but chronic pulmonary infection, which is very similar to chronic pulmonary aspergillosis in my mind, those with disseminated infection clearly need to be treated. And then again, very long courses of therapy are required for some of these patients. And so this is a paper that really was looking at what's the natural history of disease. So there's a great paper that looked at the natural history of meningitis that John and Neil wrote a few years ago. And this was really using that same data set as those initial meningitis patients. And so Derek Bays, who's one of our junior faculty at UC Davis, really did the lion's share of work for this. But to really look at what's the natural history of not just meningitis, which you can see in this green line here, but what's the natural history of dissemination to other sites, and then for non-disseminated coccidioidomycosis? So meningitis, we know, is really uniformly fatal without treatment, but disseminated disease still has a very high associated mortality rate here when you extend these patients out, and then obviously non-disseminated disease has a very low mortality rate. Unfortunately, most of the complications with coccidioidomycosis, we know if the patients are going to have those within a few months of their illness. We certainly see outliers that are even years later, but the vast majority are going to declare their complication of cocci within the first few months of therapy. About 5% develop a pulmonary sequelae, whether that's a fusion, a cavity, et cetera. And only about 1% develop these disseminated forms. And the skin, bone, and brain are really the most common, although it can certainly be at any site. And the complications can be at the time of diagnosis or present thereafter. So when we see these patients, we do a very detailed and comprehensive history and physical examination, and certainly image anything that they're complaining of. So that's sort of the pre-antifungal era, and we now are obviously in the antifungal era, which is great, and I've split up the development of these drugs into sort of the top and the bottom. So there's only FDA-approved treatment. Only 2 drugs have been FDA-approved for the treatment of coccidioidomycosis. So amphotericin B and ketoconazole, which is obsolete now. We do not use ketoconazole in the treatment of any invasive mycosis. Amphotericin B, we reserve that for hospitalized patients, those who are very sick. And then the other antifungals, if they're below the black line, we really don't use those for cocci. If they're above the black line, we do use those for cocci. So you can see after amphotericin B was developed in 1958, really there was not a lot of movement in the field for about 30 years for drugs that were active against cocci. Miconazole had there's some papers about that, and ketoconazole as well. But fluconazole, and John really pioneered a lot of this work and did just tremendous service to the field. And I think that really changed the paradigm of these patients with severe disease to have fluconazole available. Itraconazole came out soon thereafter, followed by several of the other so-called mold-active triazoles, and then lipid amphotericin B, which has reduced nephrotoxicity compared to conventional forms. So this is really what we have to work with so far. These have been very helpful for the vast majority of patients, but there's still those who really fail treatment despite the availability of these medications above the time scale. And to move on into specific treatment, so we'll separate this again by primary pulmonary disease and the next slide, which is complicated infection. And this is from a paper that Janice Blair wrote that is really one of my favorite papers in cocci. And primary pulmonary infection is really a subacute, typically pneumonic illness, and they have one of these 9 cardinal symptoms typically, so fatigue, fever, and chills, cough, night sweats, headache, chest pain, arthralgias, or rash, as you can see outlined on the right. And most of these patients are going to get either fluconazole or itraconazole, the vast majority fluconazole that's really mandated by their insurance payer, even more than what we'd like to give them. But Janice's paper, this is retrospective, the solid lines are the patients who were not treated, and the dashed lines are the patients who were treated with an antifungal. And you can see they're really not much different. And what's always been interesting to me is the dashed lines, again, the patients who did receive an antifungal have almost an uptick of a bimodal distribution of their symptoms. You can see for fatigue, there's sort of an uptick late. For fever, chills, there's an uptick. And then arthralgias, and that's probably joint pains from the antifungal itself, which can be very difficult to tease apart during the care of these patients. We often just have to stop their antifungal and see if their symptoms get better. So what do we know about treatment? We know from a paper that Neil wrote just a few years ago, and I think was in his talk, treatment does not prevent dissemination. They just disseminate later when you stop the antifungals, or their dissemination that was already there declares itself. And then from this paper, I don't really know that treatment may change the duration or the sort of the velocity or the shape of the curve for resolution of symptoms. I don't know that. We hope that when we treat these patients, but I don't think we have data that definitively proves that. I do wonder if we were able to use more effective antifungals, such as itraconazole or the mold-active azoles, if that might hasten the recovery of the disease. But again, that's purely speculative. So treatment, we treat everybody with complicated disease. Again, this is highly individualized, and there's a lot of nuance to this, but to paint with a bit of a broad brush, severe disease, we get an amphotericin B formulation. A lot of us add a triazole in combination with that. Chronic pulmonary disease, we give a chronic triazole for years. Cutaneous disease is typically several years before a trial off therapy. Same for bone and joint disease, several years of therapy before a trial off. I tend to not give people with spinal disease a trial off therapy. I think the risks of that are pretty substantial, depending on exactly where their lesion is. Meningitis, we know lifelong therapy is needed. Organ transplantation, which is increasing in frequency. Every ID program in the country is looking for ID transplant people right now. But you can see outlined in orange how many of these are years. These are years of therapy and very difficult for some of our patients to tolerate. So fluconazole, I think, has a bit of the way it's sort of taught in medical school is the most frequent reason for fluconazole is 150 milligrams once for vaginal yeast infections. For our patients with cocci, they tend to get more than 400 milligrams every day for a long period of time. And the patients, as soon as their cocci seems to be under control, they really start to complain about the adverse side effects of fluconazole. So alopecia or hair loss, cheilitis or chapped lips, and these are actually fairly severe. Their lips can actually bleed from this amount of cheilitis. And then the dry skin, and that's probably the one that patients hate the most. They just itch all the time from this dry skin. And we actually became pretty interested in this question with fluconazole therapy as a cause of alopecia. I have a different type of alopecia developing, but that's a different story. But what we found in a rat model of long-term fluconazole is that fluconazole actually induces the formation of telogen hairs. And telogen hairs actually are fairly brittle. You can sort of just put your hand through and they'll break at the root shaft. And that makes a little bit of sense why we thought women noticed this side effect of fluconazole more than men. Their hair length is just longer, so by default, it's heavier. So they will actually lose a little bit more hair than the male patients, although a lot of our male patients just think they're suffering from male pattern baldness. So we did look at this in this rat model as well as our human patients and found this telogen effluvium kind of across the board as the mechanism. The molecular mechanisms of this are unclear. The molecular mechanisms of most causes of alopecia are unknown, so similar for this exact side effect of fluconazole. So to move on to some of the more commonly used mold-active azoles, so posaconazole and itraconazole, we typically reserve these for patients failing or intolerant to fluconazole. And posaconazole, for a long time, we were really happy if we had any drug levels. So with posaconazole solution, you can see in this sort of in the bottom left, it had very low levels, and then a different formulation of posaconazole came out. In patients, levels basically tripled overnight with transition from the solution to the tablet formulation. So although we were happy earlier with any posaconazole level after the tablet, when we could get a bit higher levels, we did start to push the dose a little bit based on some work out of Stanford and David Stevens' group, that in some cases posaconazole could even be fungicidal. And when we looked on our patients, we started to see this syndrome that basically looked exactly like hyperaldosteronism. So they had alkalosis, hypokalemia, and hypertension. And when we really investigated this, we found, through some other work I won't show, that posaconazole and itraconazole both inhibit these enzymes within the sterol pathway within our adrenal glands. And what that causes is basically an increase or buildup of 11-deoxycortisol, which is a potent mineralocorticoid. And that's why you see this pseudo-hyperaldosterone syndrome. And in a subset of these patients, to add further insult to injury, if you remember through your chemistry class with Le Chatelier's principle, a buildup of this will be shunted this way, and they end up with too much estrogen. We've had some patients on chronic posaconazole come in with gynecomastia, which the patients really dislike. This did seem to be dose-related, so the patients that had this syndrome had much higher posaconazole levels than those who did not develop this syndrome. So I think that this does really show that there's a ceiling for what our target drug levels for posaconazole should be, and itraconazole preferentially inhibits this enzyme, so it can cause a very similar syndrome. Voriconazole, I think, really was just a tremendous leap forward when it came out, particularly for aspergillus and some other infections, and we've certainly leveraged that in the treatment of coccidioidomycosis. Tend to really like that for the treatment of meningitis cases as well, given its CSF penetration. The bad part about chronic voriconazole is it is toxic to the CNS at high doses, can cause confusion, delirium. It does cause peripheral neuropathy. David Denning's work has shown that in long-term voriconazole therapy. Hepatotoxicity, the rate's about 7%. And then particularly with IV voriconazole, patients can complain of photopsia, or this flashing light sensation. And that's from binding in the retina to the bipolar on and off cells within the back of the retina. It's transient, it's reversible, there's no long-term damage with that. And then in California, at least, and certainly in Arizona, but with the amount of sunshine we get, the photosensitizing effects of voriconazole are extensive and very difficult for patients to tolerate. And that's from this N-oxide metabolite that occurs with voriconazole. Other big problems with voriconazole is this photosensitivity. In some cases, can cause cutaneous malignancy. About 5% of people metabolize voriconazole a little differently, where this kind of cleaves off at the bottom. And we think that's what causes the fluoride toxicity that's seen. And you can see this figure in the bottom right is a patient that actually was referred to us for concern of multiple myeloma. It was on chronic voriconazole, and we said, no, this is fluorosis from too much fluoride given his long-term voriconazole. So all of these bone effects actually resolved after stopping his voriconazole. He did not have multiple myeloma. So these are all difficulties with tolerating voriconazole long-term. One of the other problems that comes up frequently is it seems, we kind of outlined the patients who most need an azole in the treatment of coccidioidomycosis. They tend to be older and they tend to have comorbidities. Well, a lot of those medications cause QTC prolongation by themselves. And then if we add an azole on top of that, that can be a substantial cardiac risk factor to cause this rhythm you see here, which is torsades, and can cause sudden cardiac death. Fluconazole definitely prolongs the QTC. Itraconazole does as well. Voriconazole increases it a little bit also. And then posaconazole has this sort of interesting feature where in the package insert, it says it prolongs the QTC, But if you look at their healthy volunteer studies, posaconazole probably is neutral. It probably does not cause any QTc changes. And then isavuconazole, and one of the niches that it has really filled is it shortens the QTc. So patients on multiple medications where we have QTc concerns will often give isavuconazole to try to avoid compounding the issue. The other problem with the azoles certainly is there's a lot of drug-drug interactions through these different CYP pathways you can see here, 2C8, 2C9, 2C19, and 3A4. You can see sort of that illustrated by the amount of inhibition or an induction that these different drugs have. But the problem with these is the number of cancer drugs that interfere with this pathway. Some of these are class X drug interactions. We are not able to use azoles, and this just further illustrates that despite the tremendous advance the azoles have been, we do need some new drugs in this field that do not work through this pathway and have the same degree of drug-drug interactions that the azoles do. And then the last couple slides here, really to give more of a word to clinicians, because I think in some ways we've heard the wrong message over the last 10 years. I think a lot of people have stopped checking drug levels in their patients. They've been very convinced that drug levels do not need to be checked. They think they're almost always detectable. I hear that a lot on phone consultations. I'm very much in the opposite camp. I think almost everybody needs therapeutic drug monitoring at least once, if that's all we can talk you into. I do it with at least twice a year for most of our patients, and this is why. It's accurate, it's cost-effective, it comes back in a fairly reasonable time frame, and there's fairly well-defined therapeutic ranges for these drugs. We know what levels to exceed for lack of efficacy below those levels, and then we know at what level toxicity occurs for most of these. So you can see here, this is from Nathan Wiederhold and Tom Patterson in the fungus testing lab. Voriconazole, and this is real-world human data. This is not clinical trial situations. But in 14% of patients in this real-world setting, voriconazole was undetectable. Posaconazole undetectable in 9%, and almost a third of patients had levels less than 0.5, which is what we think is therapeutic. Itraconazole, 38% undetectable. And then even if you combine itraconazole and its active metabolite, hydroxyitraconazole, still 18% are undetectable. Isavuconazole, the early papers really talked about, they tried to give a convincing argument to not do therapeutic drug monitoring because they didn't think it was needed. But still, even in these real-world situations, about so right around 8 to 10% of patients still have levels less than 1. And then the reason this has a question mark next to it over here is we've not really known what should be the maximum isavuconazole level we shoot for. And a recent paper has come out that really suggests that adverse events with isavuconazole occur more frequently with levels above 4.6. So I think that's probably around where we should shoot for isavuconazole, between 1 and 4.6 as well. And then I'll sort of end with this story. I was always struck by the fact that we didn't really have large-scale susceptibility testing for coccidioides. It's obviously very difficult to do that. It's time-consuming, even when you do easy-to-work-with pathogens like Candida, and coccidioides adds a whole different dimension to doing in vitro susceptibility testing. And the fungus testing lab had looked at all of these isolates, over 400 different coccidioides isolates. But if you look at this, a third of all of these coccidioides isolates have fluconazole MICs more than 16. And to use, for those of you in infectious disease, when we see Candida isolates with MICs to fluconazole that high, we don't use fluconazole. We use an alternative drug, but we have not done that in cocci. And I actually wonder if that's one of the reasons for the primary therapy studies. Fluconazole has not shown a difference between patients who are not treated. I wonder if we're giving them the wrong drug up front. But that's my theory, and I certainly have to prove that. I understand that. But the other problem is we also found 22 isolates with fluconazole MICs more than 64. They've been sequenced now. That's a story for a different day that we maybe can tell you in April in Tucson. And then we also found between 1 and 2% of these isolates were resistant to all of the azoles and to amphotericin B. So we are seeing more resistance. The amount of azoles we put down on our agricultural products here in California is not that different. It is very similar to the story in the Netherlands with the tulips. I think that's going to be compounded over the next few years. I have a lot of friends who are almond farmers in Northern California, and they put down a huge amount of azoles on their crops, and they don't know what any of them are. And they're very excited about this new DHDODH inhibitor, which is how alorifim works. So I think this is going to be a compounded problem, and we're going to see more and more resistance in coccidioides. And when we have patients failing therapy, I do think, just as we do in other areas of infectious disease, we need to obtain the isolate and do susceptibility testing. And there's some mouse work that's pending in this same area as well. So I'll stop here and kind of wrap up. This is so treatment of coccidioidomycosis. I don't know that treatment right now with what we've done has really changed outcomes of primary infection. I think that's probably a debate for something to discuss. Complicated disease definitely requires very long courses of therapy. I think existing options are fairly toxic. About 50% of our patients on fluconazole self-discontinue drug over time. There's clear limitations with current agents. I think this really is an unmet need. Sequestered sites are a problem. There's toxicity with long-term therapy, lack of an oral fungicidal agent. Therapeutic drug monitoring is expensive, but I think really needed, as illustrated on that slide showing real-world use, and resistance is definitely emerging. And with that, I'd like to thank a lot of our collaborators at UC Davis, but also Bridget NAU. The folks at Bakersfield have been wonderful collaborators. Manish at UCLA, Tom Patterson, who has been my mentor in mycology for a long time. I won't say how long. And then certainly the NIH for their generous support and other members of pharmaceutical industry and their support. And then the Burden Family Gift Fund, which funds a lot of our coccidioidomycosis related work. So thank you so much.
Thank you, GR.